Now it will be Dr. Lee talking about what's wrong with that pupil.
When you're dealing with a big or small pupil, the critical question is, which is the bad pupil, the big one or the small one? When I was a resident, I learned that we had to check the anisocoria and the light and the dark and then the near and all this stuff, but really, it's not that hard. First, you shine the light in the pupils. If the big pupil doesn't react, that's the problem one. Then you can go to, is it better in the light or the dark? But if you just shine the light on the pupil and it doesn't react, well, that's the problem right then and there. So even though the algorithms in the book say light and dark and all this stuff, just go straight to the light reaction first. If the light reaction is poor, then go to the near reaction. If the near reaction is good, that's light-near dissociation. And if it's bad, then you know that that's a problem that's affected both the light and the near pathway. If the light reaction is good, then you have to do the light in the dark, comparing the anisocoria in those two conditions. So basically, the second question you need to answer is it something bad? Because almost all the things that make the pupil big or small have something bad associated with it. Horner syndrome, dissection, big pupil, third palsy, aneurysm, but all the other things, if you miss it, so what? You miss old traumatic big pupil, pharmacologic dilation, they come back 2 days later and it's smaller. Addis time pupil, so what? The ones you don't want to miss are dissection, Horner syndrome, and aneurysm, third palsy. So, if the problem is the big pupil, third palsy is the thing you need to worry about. You're going to try and differentiate whether it's Addis time pupil or not, that's the ganglion, or whether it's pharmacologically blocked. If it's the small pupil, it's really down to physiologic anisocoria, pharmacologic meiosis, but the pupil reaction will be poor in that setting, and Horner syndrome. So if the big pupil is poorly responsive to light, then you want to know if it's one or both pupils. And really critically, the only thing you really need to worry about is third palsy. There are some things that are bad associated with Addis time pupil, but they're rare. Light-near dissociation is what you're going to establish clinically, and even though the books go through this long list of things that you can do pharmacologically, 1% pilocarpine, 1/8% pilocarpine, clinically, if you've established that there's light-near dissociation of the pupil, that pretty much answers the question, the same questions that would be answered by pilocarpine, but we'll go through that. So, both pupils normally react to light. That's the setting you want to check the anisocoria in the light and the dark. Because that's what you're trying to establish is it a Horner syndrome, which is badness, or is it physiologic anisocoria, which is probably present in about 1 in 5 people in this room. And that's where pharmacologic testing is useful in my experience. Pharmacologic testing, when I was a resident, corresponded to cocaine testing and hydroxyamphetamine testing. And then we do the imaging based on that. But I think that now in the modern neuroimaging era, there's sufficient false negative and false positive results with hydroxyamphetamine testing that really all we're trying to figure out is, yes, no, is it a Horner syndrome? If you can do that clinically, then no pharmacologic testing. If you can't do that clinically, then I've gone to apoclonidine. If you want to use cocaine topically, it's probably okay. Can you get cocaine in the kingdom? No. And if you say apoclonidine is probably a better choice for you, and if it's a Horner syndrome, image the entire sympathetic pathway. I think in the United States, we're all moving towards that same protocol. And one of the things I want to caution you about is this. In the U.S., we have this thing called PERLA, pupil equal round reactive to light and accommodation. PERLA. You use this PERLA thing here in Kuwait. PERLA will appear in about 1 million charts in the United States in hospitals because it's easy to remember this thing for the pupil exam. But the pupil can be equal, round, and reactive to light and accommodation, and it still be a Horner syndrome. Because PERLA only checks for equal in the light, reactivity to the light, and the accommodation, which is all the parasympathetic side. There is no assessment of 2 important pieces of information with PERLA. One is the relative afferent pupillary defect, and the second is anisocoria in the dark. So we need to assess the anisocoria in the light and the dark. So if you just look at this patient, is there anything wrong with this patient's pupil or lid? You may pass this person in the clinic. And yet, look, that's the same person in the light, and this is the dark. And you can see the anisocoria in the dark versus the light. Before apoclonidine and after apoclonidine. Apoclonidine, topically, apoclonidine is very useful because its endpoint is easy to interpret. You simply put in the drop, and the little pupil gets bigger, and sometimes the bigger pupil gets smaller. So it reverses the anisocoria, so this is the bigger pupil now, instead of that one being the bigger pupil. So the important thing is, apoclonidine has supplanted cocaine topically in my practice for the diagnosis and differentiation of Horner syndrome for physiologic anisocoria, and you need to check the pupil in both the light and the dark to detect Horner syndrome. The Horner syndrome is subtle. The ptosis that is present is usually only about 1 to 2 millimeters of ptosis. There might also be a concomitant upside-down ptosis. It's from that Mueller's muscle, the sympathetically innervated muscle in the upper lid. There's also an equivalent in the lower lid that has no name. 12% of the cases, no ptosis is present. So you cannot rely upon the entire triad, the triad anisocoria, ptosis, upside-down ptosis, and the anhydrosis. In the air-conditioned world of Houston, Texas, and probably here in Kuwait, nobody reports anhydrosis because they don't sweat anymore. They don't go outside, they don't exercise, they never sweat. Even the patients who I've asked specifically about it, who have pharmacologically confirmed Horner syndrome, it is super rare for them to say any difference in the sweating. So the book Horner, the one that looks obvious, does not look like the real-world Horner syndrome. This patient has a pharmacologically confirmed Horner syndrome, and yet in the light, the anisocoria is virtually undetectable. The only complaint of this patient, in fact, is the ptosis. The second most common error you can make with this Horner syndrome, once you've confirmed it clinically or pharmacologically, is imaging just the head. If you image just the brain, you have missed 2/3 of the pathway. So in my practice, the most common reason why someone would come to me with a Horner syndrome at a normal MR is they MR'd the wrong location. In my experience, a single study can capture the entire pathway. MR from hypothalamus down to T2 in the chest, imaging with sagittal and parasagittal imaging on the side of the Horners. A single MR scan will capture the entire sympathetic pathway. When I was a resident, we used to do all sorts of things. We'd do an MR of the head. We'd do an MR of the neck. We'd do a cervical spine film. We'd do apical views of the chest. That's 5 studies. Unnecessary. A single Horner protocol MR can image the entire pathway. But the key is don't just image the head. The neck, the dissection of the internal carotid artery is the thing you're worried about. And the other thing that you should be thinking about is brachial plexopathy symptoms and arm pain from the Panco's tumor in the chest. So just like with the vertebral dissection that we saw, the classic radiographic finding is hyperintense crescent of signal surrounding the flow void of the carotid. This is best seen on the T1 pre-contrast fat-suppressed MR of the neck. Most of the dissections in the carotid that we see are extracranial, that is, they occur outside of the brain, they're in the neck. The second thing that you should be worried about is in a child, the book always says neuroblastoma, which is true, but it's rare. But you still have to think about it. Mike, how much neuroblastoma are you seeing in your Horner's population? One every 2 years. That's the standard thing, but you have to think about it. And one of the things that we're looking for is this heterochromia of the iris. This is supposed to be a good indicator that it's congenital, but it can occur in the acquired setting. Have you seen it in acquired cases, Mike? Do you use it to obviate imaging, or do you still image them? That's my party line as well. I don't care if it's got heterochromia or not. I'm going to still image this for neuroblastoma in the United States. So here's a series of 73 pediatric Horner syndromes. 42% had some reason. And the reasons you need to be asking are, have you had any kind of trauma or surgery to the sympathetic pathway in your head, your neck, or your chest? Have you had any surgical procedures in those areas? Of 41 congenital, 53% were attributed to birth trauma. Of all those cases, only 1 was neuroblastoma. But 1 is bad, so we're going to look for it. And Horner syndrome has been reported as the only or presenting sign of neuroblastoma in children. I do image the entire sympathetic axis. Urine catecholamines, low yield. The books say to do the VMA and all these things. I don't know, Mike, you do all these things, the catecholamines? We do them, but the yield is so low. Have you ever detected the urine catecholamine in the absence of a structural MR abnormality? Me neither. So here's a patient who's a typical prototype of where the imaging can go way off base. 57, shoulder pain, down his arm, November of 2002, pharmacologically confirmed Horner syndrome, documented only nerve weakness and numbness. They imaged the head, it's negative. They do a neck CT and MR of the thoracic and cervical spine, it's negative. He has 10 intercostal nerve blocks for the persistent arm pain. Chest x-ray negative. They do a CT of the chest and it's read as mild apical pleural thickening on the same side as the Horner syndrome. So this doctor right here who's interpreting this study needs to know, look, I've got Horner symptoms and arm pain symptoms on that side. Please look on that side. If you do not give that information, you get a nonspecific reading like this. This is the supposedly normal chest x-ray. Look at the apical height. Just look where the arrow is. You see that? That is the supposed left apical pleural nonspecific thickening. That's biopsy-proven carcinoma. So imaging the head is a false sense of security. If you're just doing MR head, you are missing the opportunity to catch the two things that kill people with the Horner syndrome. Carotid dissection, which is in the neck, and Pancoast tumor of the apex of the lung. This is lung cancer as well in another patient. And the things you want to ask about are ipsilateral arm symptoms. Pain, numbness, weakness, brachial plexopathy symptoms also can occur. We've seen that in the birth trauma cases as well. This is just another case from the literature showing another tumor in the apex of the lung. This is a patient of mine, not of mine, that had a lipoma. This is one of my patients who had cervical lymphadenopathy. So it doesn't have to be badness all the time. These were reactive lymph nodes. They were biopsied. They were negative. So if the pupil is larger and poorly reactive, then you've got to test the near reaction. Because what you're trying to establish is it non-reactive to light and near, or just light? If it's light-near dissociation, that is a different differential diagnosis. Pharmacologically dilated pupils are very big pupils. You need to establish that there's no ptosis and no motility deficit. And then it comes down to antistonic pupil in the acute phase versus pharmacologic dilation if both the light and the near reaction are out, but the lid and the motility are full. So in that setting, the book says put in this pharmacologic testing, 1% pilocarpine. That's fine if you want to do that. Because if you put in 1% pilo and it's blocked with atropine, then nothing will happen. If it's acute antistonic pupil, it'll go down. But who cares? Let's say you say, I don't do this, I don't have time for this. The differentiation between these two is irrelevant, because if it's pharmacologically blocked, it'll go down. If it's antistonic pupil, it'll show light-near dissociation over time. So you can do this testing if you want, but it's just of academic interest in my experience. The only thing you need to make sure is not a third nerve palsy. And so this is kind of a prototype of a pharmacologically dilated pupil. You do this every day in the eye clinic when you're trying to look at the pupil's fundus. And the thing you're trying to differentiate is it the tonic pupil? In the acute setting, the antistonic pupil hasn't had time to develop the aberrant regeneration, and so it doesn't have the light-near dissociation yet. If you see the light-near dissociation, that nails the ganglion if there's no evidence of third nerve palsy. So here's a patient who has bilateral, big pupils, a little bit irregular. In the bright light, they don't do that much. So now we have to test the near because the light reaction is poor. Bilateral near reaction is good. That's light near dissociation. So a unilateral light near dissociation of the pupils, we're thinking about antistonic pupil. Bilateral, it could still be bilateral antistonic pupil, but you need to be worried about that Paranoid's dorsal midbrain syndrome. And so what we're going to do is we test the motility in this person that can't look up very well. And you're going to be looking for these other features. You heard in the supranuclear gaze palsy talk that the vertical gaze dysfunction usually up gaze first, light near dissociation of the pupils, and you heard about skew. So when you have those three in combination, you should be thinking about the dorsal midbrain. But any of these in isolation, I'm always going to check and make sure the others are present. So in other words, when you detect light near dissociation of the pupil, you should in your mind already be writing this. There was no vertical gaze palsy. There was no convergence retraction nystagmus. The motility was normal. The convergence was normal. So that you are convincing yourself that this light near dissociation of the pupils is not the dorsal midbrain syndrome. A pertinent review of systems negative. This happened to be this huge mass, pineal-based. Endostonic pupil is usually benign. It occurs bilaterally in about 12% of the patients. I work up bilateral simultaneous or bilaterally rapid sequential. If it's bilateral and simultaneous, I'm going to look for evidence of the dorsal midbrain syndrome. If I see any of that, I'm going to image that. If it's bilateral simultaneous, no evidence of the dorsal midbrain syndrome, I'm going to do a syphilis serology. In the books, it always says syphilis is the Argyll-Robertson pupil. That's true, but when's the last time you saw the Argyll-Robertson pupil? Peter, when's the last time you saw that? How many have you seen total? Very few, even though that's what the book says. In my experience, bilateral tonic pupil is much more common for syphilis than the Argyll-Robertson pupil, because the Argyll-Robertson pupil represents way late neurosyphilis stages. You're going to ask all your antistonic people about these things: sweating, GI dysfunction, cardiac, temperature dysfunction. Because the real thing that you need to be worried about that kills people with the antistonic people is those autonomic dysfunctions that are associated with tonic pupils: Ross syndrome, the other Harlequin syndrome. This is Mr. Addy. Pupil exam, 1995. You can see the pupils here in the dark and in the light. This pupil is not reacting properly. Bright light, still not reacting properly. Normal pupil is reacting properly. Near, a little bit better near reaction. We're going to put a 1.1% pilocarpine and demonstrate that this is indeed supersensitive. So you got light near dissociation, you got denervation supersensitivity, and a regular poorly reactive pupil, Addy's tonic pupil. This I would not work up. Next case, right? Addy's tonic pupil. But then, something happens. So here's the pupil again. Real light now, bright light. Remember, this pupil was constricting before. Now it is not. Now both pupils demonstrate light near dissociation. Both pupils have 0.1% pilocarpine denervation supersensitivity. This person, we are going to work up. Even though 12% of the cases are bilateral, bilateral gets the questions. What questions are you going to ask? Autonomic dysfunction. And you know, you don't have infrared pupillography, but I'm just showing you before and after. The segments that are the vermiform segments are the segments that are still intact. So even though the book says vermiform movement, you know, that's the parts that work, okay? The parts that aren't working are going to be in black here, and then when we fire, the tonic reaction is created by this denervation supersensitivity. And finally, pupil involved cerebral palsy you already know about. That's PCOM aneurysm. We talked about CTA, combination with MRI, MRA as a second-line therapy in any order. I like MRI, MRA because it's better for thrombosis in the aneurysm, and some patients still need conventional angiography. So this is the patient with a pupil involved third. I want to tell you about Peter Savino's law. Peter Savino's law is this: if you have a problem with the lid, the eye movement, or the pupil, big, small, lid retraction, lid lag, whatever, you must document that the other two parts of the exam are completely normal before saying it's benign. Because once you have two of the three, lid plus pupil, pupil plus motility, pupil plus lid, it's much, much less likely to be something benign, like lineated dehiscence or physiologic anisechoria or isolated oculomotor palsy. So you've got to show me that whatever the problem is, only is in one area. If it's in two of three, if it's three of three strikes and you're out. That's not benign. That's got to be worked up. And for the pupil involvement, you know that presumably compression compresses the outside pupil fibers, and vasovasorum disease from diabetes preserves the pupil fibers. So pupil sparing in diabetes, pupil involvement in compressive aneurysm. And that's the rule of the pupil. We're going to cover that more in the imaging talk. Just show you a PCOM aneurysm there. Big PCOM aneurysm here. Corolla in the PCOM aneurysm. And I'm going to show you in the imaging talk more of this, but here's a stent, placement of the catheter, coil that sucker, go home, hospital day 2, that's a cure. The last thing I want to mention to you is pharmacologic dilation. This is David Bowie. I don't know if you ever noticed David Bowie's pupil. One's big, one's small. He has no ptosis. He has no motility deficit. Is this likely to be an aneurysm? No, okay? Don't angiogram David Bowie. David Bowie has heterochromia. That's a traumatic pupil. So your job is to decide who needs an angiogram with the big pupil. Could that be an acute Addis tonic pupil? Yes. So what if you miss it, though? Okay? And I'll end there. Thank you for your time and attention.
Thank you, Dr. Lee. Next.